Yes, women live longer than men, but we're living 25% of our lives in poor health than our male counterparts. So where men tend to be pretty functional until the very, very end, and then they have a heart attack or something, not to say that that's going to be all men, but this is the trend. Most men will actually have a very full life, a short, debilitated end, and then die, okay? Women are not doing that. Women are spending 5 to 10 years demented and debilitated and requiring long-term care. Even though we're living longer, it's in very, very poor health in general. And so taking aggressive stances in menopause, hormone therapy, changing your diet, focusing your exercise can really move that needle the other way. So here are the things that women don't realize and things that I picked up in my clinic. So in 2021, I decided to focus my medical care only treating menopausal women. And I started seeing trends in blood work, cholesterol. 80% of my patients have new onset high cholesterol, meaning high LDL, lower HDLs, the negative effect, the bad cholesterol goes up and the good cholesterol goes down. And they are no changes in diet and exercise. And this is a sudden increase. And so that Zoe nutrition study I was talking about earlier, they were tracking that and they see men versus women. Men have this very linear course of hypertension, blood pressure goes up, their cholesterol goes up, all the indicators for heart disease. It's kind of age, it goes up like this. Women, we enjoy a much lower course until perimenopause. And then it cranks up and surpasses the men. So the most likely thing a woman's going to die from is cardiovascular disease. Women don't realize that. And we are getting mistreated in the hospital. We're 7 times more likely to die from a heart attack in the hospital than a man because it takes them longer to figure out it's actually a heart attack because we have an atypical presentation. But why does this happen? So the cholesterol is directly related to declining estrogen levels and how it affects the liver. And women on hormone therapy, especially early, have a more advantageous cholesterol profile. So we're rushing to put women on statins, which have never been shown to decrease the rates of heart attack in women, primary heart attacks in a woman, or decrease her rate of death from a heart attack. And they have a lot of side effects. So yeah, her cholesterol goes down, but it's not helping her risk of heart attack. There are other cholesterol-lowering medications that probably work better in women, but we're routinely recommending them for women when they've only been shown to be helpful in men. Baby aspirin, how many times have you seen one of your parents, aunts, uncles on a baby aspirin to decrease their risk of a heart attack? Only in men. Never been shown to be helpful in women.
So we've seen these studies work, but the studies are done just on men. And so because the female's more complex, we just blanket statement, put them on for women as well,
Right.
assuming that it's doing the same, having the same effect.
Right, and we're just attributing everything to aging and not really taking into account how menopause is accelerating these things and how intervention can help. And we can decrease suffering. And not only, women don't want to live longer. They want to live healthier. So they don't want to have their family having to take care of them for 10, 15 years, 5 years, however long that last slog is. I mean, I tell my kids, I want to die like my dad. I want to die like a man. My mother's been on a walker for 10 years, and she's now in the end stages of dementia. And we're struggling with having to, how do we intervene for mom, to make sure she's safe and everything. She wants to stay in her house, but that's becoming impossible. I don't want my kids to have these conversations, protracted conversations that my siblings and I are having every day. And the decisions I'm making right now are going to affect that, that course that I'm gonna have.
God, yeah, everyone listening, it really doesn't matter what age you're at. Like if you're the age of 30, it's coming for you. It's like if you're 40 or 45 like I am, I know I'm about to, or potentially in perimenopause. So to think that every single woman, if you're alive, every single woman's going to go through it.
If you're lucky enough to live long enough, your ovaries will fail.
Yeah.
And then you're going to have to deal with the consequences. Now, those consequences look different for each of us. You and I are going to have very different courses as far as the outside symptomatology, hot flashes, night sweats, joint pain, whatever. But all of our cholesterol tends to go up. Our vitamin D goes down because of our gut health. So I just started seeing these trends in clinic, and I'm like, no one taught me this. We're not talking about this, and how interventions, nutrition, diet, exercise are going to decrease the burden of disease as she ages. Right? And so let's talk about osteoporosis.
Yeah.
Okay. 50% of women will fall or will have an osteoporotic fracture before they die.
50%.
And we can decrease that dramatically. How do we do that? Hormone therapy is one. So the musculoskeletal unit works together. And when we go through the menopause transition, visceral fat goes up, muscle goes down.
Why does visceral fat go up?
So visceral fat, I wrote a whole book about that. So visceral fat is the fat that is deposited amongst our intra-abdominal organs. So it's the fat wrapping around our omentum, around the liver, sometimes around the heart, the pericardial fat, the fatty liver disease, that's all the visceral fat. That fat is very different than this fat, okay?
And
We demonized subcutaneous fat for women for years. Now, genetically, you and I probably have never had much of the curves, right? And we've worked hard to, but that fat is genetic and usually not dangerous. It's just a different body shape.
And for people to hear or know, I didn't quite understand this until my husband explained. He's like, babe, when you've got those guys that have those hard bellies, where they've got a tiny butt, and they've got the thin arms, and then they've got this belly that is just hard. That is what you're calling the visceral fat, where the fat is almost around your organs, versus you got a saggy butt, and so the fat is just almost within the skin.
Within the skin,
yeah.
Right. Okay. So visceral fat is metabolically much more active than subcutaneous fat, and it's very, very dangerous. It's very pro-inflammatory, and it increases. So the statistic blows my mind. So a woman in premenopause will have 8% of her fat will be visceral fat, okay? She goes through the menopause transition, changes nothing about her diet and exercise. That goes up to 23%.
Whoa!
23%. I don't have to tell a woman this who's been through menopause. She knows her abdomen, and that is the biggest pain point that women were coming into my office was what is happening here.
Like I haven't changed anything. My diet's been the same.
So what was I taught in medical school? That's impossible. Oh, women tend to move less. Put down the fork. Da 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 da. She's like, I'm eating nothing. I'm eating healthy. And this has happened. So that was the turning point for me, was listening to them, believing them, and then diving into the science to figure out what the hell was going on and learning about how it's related to menopause and estrogen decline, and all the things, which is the Galveston diet, that's the premise behind that. And then that conversation just exploded to all menopause. And, what started out for me, which was a very probably vain journey to get rid of some belly fat, became, what are we doing to women? Why are we not focusing on helping them get stronger so they don't fall and break a hip? Because if you fall and break that hip, you have a 30% chance of death in 1 year, even with surgery. If you don't have the surgery, if you're not well enough to have the surgery, which a lot of women aren't, you're gonna have a 78, in the 70% chance of death. And that year is horrible, marked with massive decline. So we can decrease that probably by 50%. How do we do that? We eat enough protein. We lift heavy. There's certain supplements that can be helpful. Oral calcium is not helpful. Does not increase your bone density. A lack of calcium in your diet is not great, but just swallowing calcium supplements has never been shown to decrease the risk of fracture. So really getting the message clear on strong over skinny and nutrition over calories and, lowering your inflammation naturally as much as possible and doing the work. If you're not moving your body to become stronger, you will lose muscle. That is what we're genetically programmed to do, and it accelerates through menopause. It's not inevitable, but we have to work at it.
And if you lose the muscle mass, it's your muscles that burn your calories.
Right.
So if you're eating 1,500 calories every single day for 20 years, and you have, let's say, 10% muscle mass, and that declines, and that goes to 7% muscle mass. Now you have less muscle.
So that's your basal metabolic rate,
yeah.
Right? And so you end up in that yo-yo pattern of starving yourself to get down, reducing the calories, and then you lose muscle. Severe caloric restriction, which is where we worry about GLP-1s, and if I ever have a patient on them, we're counseling them extensively.
What's GLP-1?
Oh, like the incretins, the Ozempics and the Wegovys and the semaglutides. So, I think they can be a really powerful tool for patients, and I do prescribe them, but it's with massive counseling of we must eat the protein, we must do the resistance training, we don't want to sacrifice muscle to get to a number on the scale, because then you're going to end up less healthy at the end.
This episode is sponsored by BetterHelp. Now, when life is coming at you a million miles a minute, let's be honest, it's easy to crack under the pressure when, let's say, you forget your bestie's birthday, or you lose your job, or you lose your partner that you thought you would spend the rest of your life with, ends up breaking up with you. All of that can knock you to your knees. But the good news is that there's actually a way to help manage everything that's going on with your mind, and that is with therapy. And starting has actually never been easier than it is with BetterHelp. Now, BetterHelp, guys, is 100% online therapy that matches you with a therapist in as little as a couple of days. And if things don't actually click with your first therapist, then zero worries. With BetterHelp, you can actually easily switch to another one until you find the one that you personally connect with. So if you're struggling and you think that you would actually benefit from a therapy session or someone in your life will, then click the link in the description or go to betterhelp.com/WOI to get 10% off your first month of therapy. So if someone is, let's say, going through menopause and they really, their self-esteem is diving, they've got this weight that they can't get rid of, and so you may prescribe them Ozempic or something like that, but it needs to also be piled on with healthy nutrition and then weightlifting specifically.
Exactly. So it's not for everyone.
Sure.
I think it can be a really powerful tool, but it's not, I don't think of it as a miracle. Some of my patients think it's a miracle because they've worked their whole lives, and it's taken up so much mental space for them, and to take that mental part of it off the table. I've never had that, so it's hard for me to understand, but to listen to them and watch family members who struggled for their entire lives, suddenly to have that mental chatter of food being taken off the table, and now they can think about exercise and nutrition. It gives them that space to build out the rest of their lives in a healthier way. It's really amazing. But, when the patients come in, I have an hour with my patients, and I'm very fortunate that I can run a clinic like that. And they have to unpack their menopause trauma. So we have to give them time and space to do that. And then we have a full discussion on hormone therapy, nutrition, exercise. I usually bring them back a few weeks later. And then, I have a body scanner where I'm measuring muscle mass and visceral fat. We're having very intense conversations around that. So it's kind of a stepwise progression. Also, testosterone can be really helpful for muscle mass and bone density as well.
Okay, so that was so beautifully broken down. And so just to make sure that I understand, though, the visceral fat it goes to the belly. Because I was always wondering, why is it always the belly fat as women get older? Is it that it's becoming visceral fat?
Right. Yeah. So you do have a little more subcutaneous fat here, and that frustrates women because they don't like the way it looks. Yeah. But really, it's for the health reasons and the long-term health consequences, it's the intra-abdominal fat.
Got it. Okay, and I actually, do you know Dr. Amen, the brain doctor? So Dr. Amen once said to me, and this has always stuck with me, genetics are the bullet in the gun, your lifestyle's the finger on the trigger.
Yeah.
Do you feel like that's quite accurate, at least somewhat, when it comes to menopause, where it's look, you're going to go through it's genetics, your gender, you're a female, but your lifestyle will, and how you handle it will dictate whether it's a torture where you really feel like you want to sadly end your life, or that it's navigatable?
To some point, there are trends, right? So we know that women who have an anti-inflammatory diet, more Mediterranean or Galveston diet-esque nutrition, tend to have less outward symptoms. So less hot flashes, less joint pain. They do kind of better through the transition. But that being said, you can have a woman with perfect nutrition who can suffer horribly. But in the trends, we do tend to see that women are less symptomatic in general if they have a healthier lifestyle and can maintain it going through the menopause transition. But nothing we know of yet will extend the shelf life of the ovary. So there's lots that we can do to decrease the shelf life of the ovary, like have surgery. So you have a hysterectomy, you lose 4 years off the life of your ovary.
You lose 4 years?
Yes.
Whoa.
There's a disrupted blood supply to the ovary coming from the uterine side. When we surgically remove that uterus, we cut that blood supply. So we lose about 4 years. And I never counseled my patients about that. And that I didn't know. And now I just scream it from the rooftops, about, look, if you medically need a hysterectomy, absolutely, can be life-changing for people. But you need to remember that you're going to go through menopause 4 years earlier than you would have. You have a tubal ligation, it's about 1.5 years.
What is it?
A year and a half.
No, a tubal.
Oh, tubal ligation. You have your tubes tied
Oh.
as contraception. So again, we're disrupting blood flow there. And so women tend to go through menopause a year and a half early. Your genetics play a huge role. You know, I always ask my patients, when they're perimenopausal, how old was your mom? I don't know. We don't talk about it. Go home and talk about it, you know. Genetics play a big part of it. If you smoke, you lose years. If you don't have any children, you lose years because you ovulate more.
And when you say you lose years, you mean you go into menopause earlier?
Sooner.
Right.
Sooner. So
it's weight as well, I believe, right?
So plus or minus, if you're super thin, you tend to go through a little sooner. And if you're obese, you tend to go through earlier. So normal weight, you tend to keep.
Of course.
Yeah. So yeah, that kind of goes both ways.
Yeah, I mean, you list a bunch in your book and it was fascinating to me.
To me too. I mean, no one taught me these things. I knew about, chemotherapy and radiation but I remember reading it and when I was preparing for the book, being like, how many hysterectomies did I do? Where I did not warn the patients that, we're leaving her ovaries behind for a good reason, that she would go through menopause sooner. Like this just wasn't common knowledge and I was a very well-trained OBGYN.
Unfortunately, you didn't know, right? So it's like you can't really beat yourself up over that, but I totally understand. But thinking through that, and then you said something like, if you've been sexually abused?
Yes.
I was like, what the hell?
So I think it was 9 years. So if they were sexually abused as a child and their child was sexually abused, they go through menopause like 7 to 9 years sooner than they would. That puts them in like premature menopause level. And that's a super high risk category for chronic disease.
Wow. So the menopause then basically activates the potential to chronic disease, which is why it's so dangerous, because if we are doing things, obviously the sexual thing that is unavoidable
It just highlights that chronic stress will take life off of your ovary.
Right. Exactly, yeah. What about an abortion? If you've had an abortion before?
I didn't see any data on either termination or miscarriages. Here's the thing. Every month that we ovulate, we lose about 11,000 eggs with each cycle to get one egg out to ovulate. It's not a very efficient process. And so the women who are not ovulating, either from oral contraception, tend to preserve their ovaries a little bit longer. It's not a huge amount. And then women who are pregnant 2 times have the longer ovarian life. So no pregnancy, you tend to ovulate more. Right? So like nuns who don't need, people who don't need contraception are ovulating, they tend to go through a little bit earlier. But if you have a lot of children, probably stress. So if you have more than 4 children, you tend to go through menopause earlier than you would have as if you'd had 2 children.
So again, if you don't have any kids, you go into menopause earlier. And if you have too many kids, you go into menopause earlier.
For different reasons.
Yeah, interesting
reasons.
how it's different reasons, but it's still... And
so I can't imagine if you terminate a pregnancy, that's never an easy decision for a woman, or if you have a miscarriage. So these are high stress situations. So I think you would go through sooner.
Because of the stress. So thinking through all of these, like there's certain things that, right, you don't want to make decisions based on your menopause going, sooner or later, but to at least understand, because you look at either your friends, right, and you compare yourself to your friends or other women or women in your family. And so thinking that it's a problem, quote unquote, with you, or there's something wrong with you. I love that you just debunk it, because you're like, look, this is just how it is. If it's this, then it's this. If it's this, then it's this, and the knock-on effect. And so for me, who I haven't had a child, I have massive gut issues, I haven't had a period in like over 10 years, you better believe I'm like, okay, I'm counting the days, I'm 40, I'm about to turn 45. Like, I'm not scared, I don't worry about it, I'm not tense. I just love the knowledge that I know, A, what I'm about to face, and then B, what can I do about it? And so that's where I'd love to now take this discussion in talking about the impact that it can have on you, and then we'll talk about what to do. But hearing the stats that it's almost up to 70% of women initiate divorce between the age of, I think, 45 and 60. When
the divorces happen. Yeah. So I have a couple of patients who are divorce attorneys, female divorce attorneys, and they feel very strongly about this. And they said, listen, women divorce for many reasons, and they do initiate the divorces more than men. Women are more likely to say, I'm out, than a man. Men tend to be a lot happier in marriage than women. So go figure.
Yeah.
But women either menopause is very freeing in some ways. It really a lot of women I find are finally able to prioritize themselves because they are just not doing well, and they realize if I don't take care of me, I see the path I'm headed down and I don't want to go there. So they all of a sudden boundaries go up. They're prioritizing their own health, their own mental health, their own physical health, and people who used to depend on them to always be available get upset. So women are realizing they're not in a great relationship. They stay in a relationship for the kids or for financial reasons or whatever, but now they're no longer willing to do so. The sexual dysfunction breaks up a lot of marriages. So we see, and I was just looking at these stats, we see probably 50% of women will have, at all times, if you poll all the women today, 50% will have some form of sexual dysfunction right now. Okay, now that could be, there's kind of 5 buckets when we talk about female sexual function. We have an orgasmic disorder where they can't have an orgasm, okay?
So you can get turned on, you just can't climax?
Right, so for women that's primary or secondary. So primary or anorgasmia is and that's about 10 to 15% of women will never in their lives have an orgasm. They don't talk about it. No one's prioritizing their health. And imagine if that was 10 to 15% of men. What would happen in medical research?
Oh, you would get Viagra would be made.
Like whatever, So then there's secondary anorgasmia, and we see this a lot in perimenopause. So the time to orgasm can get a lot longer, and the intensity of the orgasm becomes less because we're changing down there. The loss of estrogen is leading to decreased blood flow to the area, the tissues become thinner, we can have pain. So pain's another bucket. So if you have pain with intercourse, usually due to some form of genital urinary syndrome of menopause, GSM, or vaginal atrophy is the older term, or senile vagina. Senile vagina is the term that was used like 20 years ago.
Oh God.
Yeah.
I don't mean to laugh, but the laughing is out. I can't believe how ridiculous that it was accepted that we could call a vagina senile, but really it's menopause.
It's menopause. So that loss of estrogen, those tissues from the pubic bone all the way to the sacrum are heavily dependent on estrogen for their health and their vitality and their ability to fight off disease. So the best treatment, recurrent UTIs, urinary sepsis is a huge reason for an elderly woman to be admitted to the hospital, okay? What is the best form? 50% decreased rates of recurrent UTIs and sepsis would be vaginal estrogen, putting estrogen back in the vagina, localized. It's very safe, it's very low dose. None is absorbed into the system. So even a patient with active estrogen-dependent cancer could use vaginal estrogen safely with no worries of increasing her recurrence. But we're not offering it.
And that is a prescription that you go to get your doctor.
Yeah. So, there's just so much out there. So pain. So how do we treat vaginal pain due to GSM? Vaginal estrogen works almost 100% of the time. Restore the health of the tissue, give her a break, tell her nothing down there until this tissue heals, and then try again.
This is all going to be like a lining of your products, right? That you're going to start to sell.
Now, lubricants, there are lubricants and things that can kind of help, but it's not treating the root cause, which is restoring the health of the tissue. I think all women should use lubricants. I just think they're fun and they can decrease friction and just make everything easier. So maybe one day I'll come up with a vaginal lubricant. And then there's arousal disorder. So arousal disorder is usually when a man's suffering from low libido. It's really an arousal disorder. He's having trouble having an erection. There's nothing wrong in his brain, saying, I want to do this. Most men usually want to do it. But for women, where I see the marriages fall out is they're having untreated pain and they're just turning their partner, because it hurts so much and it breaks up that relationship. Or they're having HSDD, which is the most common thing, hypoactive sexual desire disorder. That is in the brain. That is the signal to your brain that this is a good idea and we want to do this. And that tends to go very, very low in the perimenopause transition. And so multiple treatment options for that. We have FDA-approved medications. We have testosterone, which is shown in menopausal women to be very, very helpful. Here's the problem. Doctors aren't asking, they're not offering. They're telling women this is the time of your life, we'll have some wine, go home and just do it, and you just put up with it. And it's ridiculous. So.
God, and then to think about all of that happening. So you're no longer aroused by your partner. It's both physical and mental. You go to the doctor to seek help. They're just like, suck it up, drink wine, give it up, like whatever the words are. And now you're definitely not feeling sexy after that. And so to then think about how then that has a knock-on effect in the actual relationship itself, because I've been married for 21 years.
Yeah.
Oh yeah, of course. I mean, forget about just not the intimacy itself, because I'm very much advocate for, I think sex is very important in relationships. And the thing me and my husband always said is we'll never have a relationship that has bed death, which is we don't have the intimacy. And so when I think about how women are struggling, they don't have the same arousal that they used to. Now, to your point, their partner now almost feels like, is it me? They're not attracted to me. And then they make it about them. What that can do in that relationship dynamic.
So here's what's also happening. He's having trouble having an erection, which is a normal part of aging for a man. Most men will have a decrease in the ability to have an erection, right? He goes to the doctor. Within 2 minutes, he's given a prescription for a Viagra or one of the other, Cialis or one of those meds, okay? And they work great for most men. He goes home to a woman who's having pain or hyperactive sexual desire. I'm like, where do those doctors think those Viagra-laden penises are going? Like, no one's asking, how is she doing? Is she having pain? So there's a big mismatch. And here's 2023, they looked at the data last year. 85% of women are going to the doctor and complaining of some symptom of menopause. And usually the cliche ones, okay? Not the joint pain, because most doctors don't get that yet, right? But like hot flashes, all docs know. A woman over 45 not having a period with a hot flash, she's in menopause, right? Only 10% are being offered any therapy at all. And the majority of those women are being offered an antidepressant, which is a killer to most women's libido.
Oh, yeah.
So you finally get the bravery up enough to go and ask. You're not being given the gold standard treatment, which is hormone therapy, and you're given an SSRI, which has tons of side effects and is killing your libido.
What are you doing with your husband in order to make sure that you don't become another statistic?
We have had our ups and downs like every marriage. And at 35, I thought I was on top of the world. I had a great life at 35. So my kids were like little and they loved mommy, and I was in great shape. I mean, I looked good. I probably, was over exercising to be thin. I loved my job. And I never would have imagined that over the next 15 years that I would lose 2 brothers and my dad, that I would, leave a position that I loved to go out on a total whim and do something crazy. I would never imagine going through a pandemic. I would never imagine leaving the country for 2 years to go support my husband in his work. I would never imagine that I would almost get a divorce. And so that my marriage would get worse and then better, and that I would stand on a stage or sit on a podcast that, 20 years later and be able to talk about it. And so I found my voice to tell him what I really needed. And that really came with learning to prioritize my own needs over that of my, so that I had to put him on my own oxygen mask so that I could take care of the needs of my family. And thank God he went with it. He could have just lived that way forever and been happy. He was kind of that typical guy. He didn't see it until I pointed it out to him, and it took him a minute to figure it out. Like he was kind of the typical TikTok guy for a while of, oh, you think I'm so horrible, da da da. I'm like, no, I'm just telling you that this isn't working for me. And I got counseling, so that I went to therapy and I worked on me because I wanted things to be better for our family, and realized that, and then once I replaced my hormones, I changed my diet, I changed my exercise, I got therapy, I prioritized myself. Like, that's where I am today.
There's so much beauty there in that story. The idea that it's never too late.
Never.
And the fact that you said that you are happier now than you've ever been in your 50s. And going back to where we started, where you said 1 in 5 women quit. Just understanding and knowing it doesn't have to be like that. That the brain fog, everything that makes us feel badly about ourselves, that can potentially then lead to suicide or divorce, and like all of these things happening so late in our life, it doesn't have to be like that. And to hear that you are like the canary in the coal mine, if you will, that you just have shown that. You've shown that if I just prioritize myself, this isn't actually neglecting my family, because I think that that's sometimes what happens, where it's like, I'm gonna do me now. And I get it, you've spent your entire life serving other people. So now you're like, it's time for me. I'm in my 50s. When am I gonna get my time? It's gonna be now. In being able to do it, like, I'm taking care of myself for the sake of my family, for the sake of my relationship, for the sake of my future. And now you saying it's the best time of my life, I need people to hear that. That's so strong, girl. That's so strong.
And I want, I went on a limb to open a menopause clinic, which didn't exist.
Oh, yeah.
I got to pick and choose the medicine I wanted to practice. And my husband was fully, he was like, do it. I didn't know if it'd be successful. I didn't know if anyone would ever come, And he said, this is the time. And if it fails, it fails. But you'll never know until you try. And this is your passion. This is what you want to do. And I took my girlfriends out to dinner and I was like, do you think this will work? Like, would you come to me? And they're like, of course, this will work. Trust me, you know what you're doing. And I opened a practice that no one really was doing, or very, very few people. I've found others throughout the country, the menopause, what we call them, who are practicing medicine the way
menopause.
Yeah. So
that's amazing.
The menopause is me not, so when I first started talking about menopause on social media, I felt like I was very alone. And I was getting a lot of pushback from other gynecologists who were on social media who were like, what are you talking about? Hormones kill people, cancer, just get over it. Menopause is no big deal. You're making it a big deal.
And I'm betting you a lot of those were women as well.
They were. And I just kept digging down and going deeper, because the comments I was getting back, thank you, you're helping me, you're giving me tools, you're educating. And so then I found Kelly Casperson, who's a urologist, and she does a tremendous amount of education on female sexual health. Like, everything I know about libido and sexual wellness, I learned from her. So shameless plug for her book, You Are Not Broken. And she and I just became really fast friends, texting all the time. And, we're kind of fighting the establishment, because there really is the old menopause versus the new menopause. And there are people who are entrenched in the idea that this is a normal, natural part of life, and you should just soldier on and get through it and only take hormones if there's no other option, because they might kill you. And that is ridiculous. And we are harming women in the process. And we're causing earlier deaths, more debilitation, more disease, than if we embrace, I'm not saying not embrace your menopause, absolutely. But what worked for you in your 30s is probably not gonna work for you in your 40s, 50s, 60s, and 70s. And I'm just trying to lay out some actionable items that you can do to change the trajectory of your health for the rest of your life. And finding other women who are just as smart as I am, believe in the research as much as I do. It's just the most beautiful thing ever.
If you enjoyed that, then make sure that you click right here, right now, so that you can enjoy the full episode.
The most likely time for a woman to commit suicide is between the ages of 45 and 55. We see a quadrupling of depression rates through the perimenopause transition. 80% of us